I'm going to begin by reading the mission statement of the American College of Surgeons. Most of our organizations have mission statements. We may or may not live by them. I will tell you that I and my relationship with the college believe we do, and you can judge it today based on what you hear. The mission statement is brief, but it says the American College of Surgeons is dedicated to improving the care of the surgical patient and to safeguarding standards of care in an optimal and ethical practice environment. You judge today from the community, from our hospitals, our surgeons, whether you think we are living up to that. And in the discussion with the panel and the Q&A, we hope we can flesh that out, and where we are not meeting the mission statement, part of this inspiring quality is really meant to get at that. I'd also like to thank particularly Chris Van Gorder and Scripps Health for being willing to co-sponsor this event with the American College of Surgeons, and Dr. Mark Talamini, who, along with myself, you'll meet Mark, Professor Chair of Department of Surgery at UCSD. He and I have been the local contacts, but in fact, we have really just done what the people at the college have told us to do. I've learned over the last few years that's the way to be successful in the American College of Surgeons. Just listen to the staff. And in this case, it's not only the staff at the college and Dr. Hoyt leading that, but it also is Weber Shandwick, really the communications firm that the college is working with and has helped put this together. And I'd really like to recognize Nancy Longley, Stacy Raymer, and Jackie Voss. Would you all stand up? Because you've really done the work in putting this all together. We are part of what is I don't know, David, we haven't used this term, forgive me, but I think it's Occupy the United States. And we are trying to, if you will, occupy communities, to have sessions like this, to be evangelistic about it, spread the gospel about patient care. And we all recognize, we read it in the paper, we listen to it on the news, we've got a broken healthcare system, costs are skyrocketing, out of control. We can't afford what we have. And yet we are, as healthcare providers, for those of you in the community need to know, we are committed to helping solve this problem. You'll hear today it probably based on some of the political impasse that goes on in Washington and frankly in Sacramento, that's not where it's going to happen. It's really going to happen here with us, those of us who are patients, who demand quality and cost-efficient care, those of us who are providers who have to meet that. I think what we talk about today can be summed up nicely with what you all know about. It's become almost a cliche, but I think it's fundamentally true, and that is the value proposition. That is value equal quality over cost. And I like to point out that quality is what the patient sees. They see what the quality is, the outcome of their operation in the case of surgery. They see their bill. They see the cost. They see bankruptcy if they can't afford to pay it. But value is what we must achieve. And the good news is that quality and cost are not mutually exclusive. In fact, the proposition has been evidence-based, proven that by improving quality, which is what today is about, we can decrease cost, decrease the variation in care, and really have a sustainable healthcare system for those who will follow us, either as patients or as providers. It involves change, and that's not easy. There's a number of aphorisms about change. One of my favorites is that everybody's in favor of progress, as long as it doesn't involve change. A couple of years ago at the Pacific Coast Surgical, the presidential address had a very creative title, I thought, which was, "Change is Good. You go first." And I think we have a number of people doing that. Well, perhaps the best aphorism, and I think our keynote speaker, who I will now introduce, will touch on that, is what Mark Twain said, which is, do what is right. You'll please only some of the people, but you'll astonish the rest. And we really hope today that what we are doing, what you are doing in the College of Surgeons is going to astonish the American public that we are committed to a higher quality, more cost-efficient healthcare system. One of our charge, Mark and I had, was to have a keynote speaker. And they said that what they did at Hopkins is that they had a United States Senator. And Washington, D.C., I think they had a United States Senator. And in Chicago, I believe they had a United States Senator. So we invited a United States Senator. I thought for sure I could get Senator Feinstein. Her father, Leon Goldman, was one of my surgical professors. She used to make rounds with him in San Francisco, where I trained, and thought it was a slam dunk. That's what I told the college. Diane said she couldn't come, and so then we thought, well, we'll go to the lieutenant governor. He thanked us and said he couldn't come. So we said, well, we'll go to the Secretary of Health and Human Services, Ms. Dooley. She said, I'll come, but then she had to have surgery, so she couldn't come. So I was at the college meeting, the Board of Regents meeting, and prevailed upon David Hoyt. And I said, David, would you come? Because he's been involved in this, but was not going to come here. And would you please come and be our keynote speaker? To tell you what kind of a friend David Hoyt is, we walked over to his secretary's desk, and he said, what am I doing on March 2nd? And she paled and became diaphoretic and trembly. And she opened this book, which was booked, and he said, clear it, I'm going to San Diego. And I don't think she's ever forgiven me, Dave, but David Hoyt did agree to come. And in fact, we're lucky. Better given the message today than Feinstein, than the lieutenant governor, than the secretary. I think nobody more than David Hoyt should be the keynote speaker for this. David comes by his interest in all of this honestly. Talking about it this morning, his father was an orthopedic surgeon in Ohio and actually wrote the original Orange Book that some of us have seen. Mark Tellamini has a copy. And it was the original setting really the standards for pre-hospital care for paramedics and pre-hospital providers. David edited that book, and he went on to have a career, went to Amherst College, where he graduated with honors in English, not pre-med, but in English. And David, I hope you'll forgive me, but I always think one of David Hoyt's really most distinctive honors is that he is the only person, never mind surgeon, that I know who went to Woodstock. David may or may not wish to talk about Woodstock. David went to medical school in Ohio at Case Western Reserve, but important for us, he came west and did his residency at UCSD and also did his fellowship in immunology at the Scripps Research Institute with Dr. Cochran. Is Dr. Cochran here yet? Good. Charlie, would you stand up, please? Charlie Cochran, I think the reason I was able to get Dave Hoyt to come is that I said we would have a little dinner with Dr. Cochran. And I just want everybody in this room to know that Charlie Cochran, who's now retired, has been one of the most prodigious physician scientists in the country. His contribution is the development of surfactant. Colleagues such as David Hoyt and Ron Mayer. John Najarian got his immunology training at Scripps Clinic at the TSRI. So Charlie, thank you for being here. I think that's why David was willing to come. Dr. Hoyt has made incredible strides in his first 2.5 years as the new Executive Director of the American College of Surgeons. I've known David for a long time. I was on the search committee. Dr. Brett asked me, finally, would you please comment on Dr. Hoyt, because I thought I had a conflict and should remain silent. Never told David this. So I said, well, yes. As my father always said, there's nothing wrong with nepotism as long as you keep it in the family. So I just made one statement. I said, Dr. Hoyt will always say what he does and do what he says, and we can count on him, and he was a unanimous selection. So it's really my pleasure and honor to introduce our Executive Director of the American College of Surgeons, friend and colleague, Dr. David Hoyt. David, Pogo, I think you and I share, is a great philosopher, and everybody knows about the enemy is us. But what you may not know is Pogo also said, we are surrounded by insurmountable opportunity, and I think that's what today is about.
Well, good morning, and thanks everybody for coming. Brent, thank you very much for that introduction. Thanks, Chris and Mark, for helping to co-moderate this. You know, it's really a pleasure for me to come back to San Diego and be part of this, and I'm not running for the Senate, although it sounds like you might be able to do that. What I'm going to do is try and frame the discussion this morning and tell you why we're having these kinds of forums across the country and what we're trying to do as a professional organization. We are the largest surgical professional organization in the world, and what our commitment to quality is on behalf, ultimately, of our patients. Now, if you look at an organization like the college, we really have three areas of focus: quality, education of our physicians, and most recently, really only the last 20 years, advocacy. And because of the complexity of the health system we all work in today, if you're really going to establish quality and education standards on behalf of your patients, you have to also be effective at advocacy. And I want to show you, to a certain extent, how this pressure and how this opportunity for participating in the quality discussion also gives us an opportunity for advocacy. Now, we are about to embark on our 100th anniversary, and over the last 100 years, the college has really been intimately involved in the development of quality programs. It started back in 1917 when the first hospital standards were developed for what was to occur in a hospital. This ultimately became what is now known as the Joint Commission. In the early 50s, the American College of Surgeons, it's fascinating, but they finally joined with three other organizations to develop the Joint Commission outside the college. And the reason is that they had, for the previous 35 years, not been charging for certification, and it was becoming too much of their budget. It's amazing. Commission on Cancer, the Committee on Trauma, most recently programs like NSQIP, which we're going to talk about, those have been our tradition, and really at the front edge of what we've offered on behalf of our patients. Now, in that process, we have developed what we're calling 4 guiding principles or pillars. And these are really the pillars of the continuous quality improvement cycle. The first is to set standards that are focused on individual patients, backed by research when possible or by consensus when not. The building out of the infrastructure for a program, including the articulation of appropriate staffing levels, equipment, checklists. The identification of ways to measure outcome through rigorous data that's based on medical chart review, post-discharge tracking, and then finally, subjecting yourself to peer review, external verification. This is really our bond with the public, to have a verification program that assures the public that what we say we're doing. And a trauma center is a wonderful example. Now in San Diego, there's probably no other community in the country where the use of these principles in developing the trauma system over 30 years ago have really sort of been a model for how we look at this. The trauma system, as an example, is truly an example of disease management, and these principles are embedded in this concept. And I think you're all familiar with the wonderful impact this can have, but that graph in the right lower part of the slide is the original graph that showed that compared to no trauma system, preventable mortality was reduced and has held at that threshold for the last really 32 years. Said another way, this is really our good housekeeping seal of approval based on these quality pillars, and that's really going to be the core of the message this morning. Now, there are 2 major pressures on us, all of us in medicine today. And the first is the quality movement. And to a certain extent, this started with the Institute of Medicine report to Err is Human. It was championed through the subsequent report, Crossing the Quality Chasm. And I think that led to a lot of proliferation of quality measurement efforts, programs, etc., and a lot of confusion. But actually in the last year, there has been consolidation and alignment, at least at the federal level. And the evidence for that is on this slide. At the top there is the National Quality Strategy that comes out of Secretary Sebelius' office. And you see the emphasis is on improving care, better care, healthy people and communities, so prevention efforts, etc., and making that affordable. When you look at the largest payer, CMS, they are reflecting exactly the same philosophy through the triple aim of Don Berwick. He's no longer the administrator, but the impact that his philosophy had on where CMS is headed is, again, to improve the experience of care, improve the health of populations, and reduce per capita costs. And finally, the same organization, the Institute of Medicine that started the quality chasms, led to the original To Err is Human report, in the last 2 years has defined the concept of a learning healthcare system as the ultimate goal, where the concept and contextualization of evidence, and their goal is to have decision-making by 2020, 90% of the time reflect best evidence. So that's one huge change that we're under. Now, who has a learning healthcare system today? And I would argue that the American College of Surgeons is well on its way to being a prototype in medicine for that. We use best evidence to establish surgical care standards. We have then disciplined ourselves to measure outcomes through databases that are designed to assure performance against those standards. When we reflect on that data and find deviation, we use that to reconfigure new clinical trials. The introduction of new technology is able to be done through this kind of process, and that again then redefines best evidence. So this concept of a loop of continuous quality improvement is embedded in the way we think in our programs, as well as many of your hospitals. The other major pressure that we're under is the financial one. And we've all seen these slides, 2020, $4.5 trillion, 19% of GDP. Looked at another way, we currently, with all of our taxation opportunities, generate at a federal level 18% of the gross national product. We consume, with Medicare, Social Security, and interest on our debt, 16%. If you think about that, the real dilemma we have is that we, without raising taxes or without changing the revenue structure that we currently have, we're using most of our health care dollar or most of our federal dollar for health care delivery and other entitlements. And the problem is that then is making us make choices that we as physicians really need to appreciate if we're going to participate in this. Now, Uri Reinhardt, who's a somewhat controversial economist at Princeton, puts it this way, that the net social value from a health system really equals the gross value from the actual health care you give to patients minus the opportunity cost to society. And a lot of what you're seeing in Congress being frozen right now is people debating just how much are we going to put into health care relative to research, relative to infrastructure for roads, and all the other things that government does. And I'm not sure we have an answer to that, but I think that's fundamentally important for us to understand. Well, our message is that in the American College of Surgeons, we've got something to bring to the table, and we're going to show you one example that is really behind this. And we've found a way to lower costs and increase quality, to Brent Eastman's point, the value equation. And it's based on this program called NSQIP. Many of you in San Diego are participants of this, and I really want to congratulate you on the forward thinking to subject yourself to measurement of surgical programs and use this as a tool to improve. Now, the actual premise, if you're not familiar with NSQIP, is really based on this slide. And what this is we refer to as a caterpillar diagram, and it simply shows the performance, in this case, of 450 hospitals against some outcome. This could be surgical infection, this could be DVT prophylaxis, whatever. And what you see on this is on the right there in red are hospitals that against this standard are performing less than you would expect. In green on the left are hospitals that are performing better. When you share this kind of data with physicians, it's hardwired into our psyche, if you will, to try and improve if you're in that red zone. Now, you can say that, and we all sort of know how we would react if our performance in our practice showed a higher than expected surgical infection rate. But the data shows that actually this actually works. And here's a very important study by Bruce Hall and Cliff Coe, who've been fundamentally involved in the development of this program. They studied 100 hospitals, looked at it over 3 years, and showed that by participating in this kind of effort, 82% reduction in complications, reduction in mortality, and that worked out to about 1 complication per hospital per day for an average 400-bed hospital. When you couple that with the cost of a complication, which is probably conservative at $11,000, each hospital then is actually having a cost savings of $3 to $5 million. You spread that across all the hospitals in the United States, and you're talking about a significant contribution to this healthcare dilemma of billions of dollars in cost reduction. Now, the other important aspect of this is this drives a conversation. And one of the things we're hoping that these forums will do is bring you together closer as a community and creating collaboratives such as we have in Tennessee or Michigan. And these collaboratives, again, are based on the database, but what they do is they foster people coming together, sharing data with each other, and then finding solutions and common problems to work together on overall to improve. Now again, San Diego has been an incredible leader in this regard. And again, I'll fall back to the trauma system. But in San Diego County, there has been a conversation for 30 years between the trauma centers and the county through the Medical Audit Committee, which is really the prototype model for these collaboratives. And I'm sure that with time, you will move to this in a broader fashion. Well, the surgeon of the future, and probably physicians in general, really are going to be parts of teams. They're going to be leading safe, high-performance teams. Increasingly, the integration of surgical and non-surgical skills. I had a chance to see the hole in the ground for your new cardiovascular center. That's a wonderful example of this. And we're increasingly all going to be parts of systems of care. We're going to be held to a basis of evidence basis more than we have in the past. Outcomes data, which will actually include public reporting. These really are givens today. We're not there yet, but that's the direction I think healthcare is going. So we've really got to be prepared to participate. And again, the NSQIP program, I think, is a wonderful example of that. Now, I just want to end a little bit on another topic, which is really quality in education. And how do you know that a surgeon is competent to do a new procedure? And that's a real challenge, because in the past, we've sort of followed the see one, do one, teach one model, and we know that that's not objective and precise enough, particularly with the concepts that are being put forth with new technology. So we've extended this concept of inspiring quality and objectifying and verifying education through the concept of accredited education institutes. And these are designed to be throughout the country and be places where surgeons can learn new skills and actually have validated that their learning has been appropriate. And there's a wonderful example again in San Diego at UCSD that Dr. Talamini and his colleagues have developed, the Center for the Future of Surgery. So these are the kinds of things, in addition to the quality programs at a hospital basis, that really need to be part of our healthcare thought process going forward. Said another way, we're kind of redefining our concept of professionalism. And whereas 100 years ago, the use of autonomy, authority, and assertion, which surgeons are pretty good at, has really evolved into further collaboration, evidence basis, measurement, if you will, transparency. And really we're redefining our profession on behalf of our patients as accountability. This gets back then to the coupling of this quality initiative to our advocacy efforts. And to that end, we've developed the Inspiring Quality campaign, Highest Standards and Better Outcomes. We've taken this to Capitol Hill as a kickoff in May. We've had desktop conversations with many legislators to try and get them to understand this. And it's been very interesting to see the effect that this has had, as opposed to just going in and talking about payment reform. or medical liability reform. Leaders at the legislative level are listening. They're interested in what physicians have to say, particularly when you talk about things that ultimately affect patients. We've started these quality forums as another way to engage at a more local level this conversation, and we would encourage you to continue this in the San Diego community as well. And we're spreading this across the country, as you can see. We've developed a lot of tools and ways to help you and assist you both in your hospital and within your community, and these are all available to you, and we can provide them through the web or just simply by asking. Finally, I'd just like to thank Dr. Eastman for his contributions in San Diego, but also the fact that he is now the President-Elect of the American College of Surgeons. And it just shows you what outstanding leadership he's not only provided in San Diego, but is now going to provide really, literally, to the world. I want to end with a little summary video that kind of puts this together for you and kind of gives us our core message. And I also want to thank our colleagues from Weber Shandwick for helping us put these things together. So if we can just sort of click on that. And Brent, thanks very much for the opportunity to be with you today.
Well, I'm thanking Dr. Hoyt. In the interest of time, why doesn't the panel assemble on the podium? Dr. Hoyt, thank you. Dianne Feinstein might have been good, but you were better. And David Hoyt has always inspired me, and I guess what I would, again, like to say, Dr. Cochran, you know David Hoyt as a physician-scientist, made tremendous contributions. He could be up here just as well talking about his contribution. It's in surgery, critical care, and the immunology, and understanding the immunology of the injured patient. So I hope you are as proud of David Hoyt as we are with his contributions. David, he gives you 2 thumbs up. Thank you very much, David. What I like about this is the concept we hear over and over, evidence-based. How many people in this room are operating surgeons? Now, if you trained when I did or in that realm, it was not evidence-based. It was eminence-based. And you know, you did what the professor told you to do, and we have some eminence-based surgeons on the panel today, Dr. Dilley, and we'll see if he has transformed himself. So in the interest of time, I'm not going to go through the distinguished and impressive bios of the panelists, but rather, and we've rehearsed actually this morning, each panelist is going to introduce themselves, what they are, what they do, and then they have 5 minutes, not very long, but to give you their kind of summary of what we're talking about today, and then we'll hopefully have a little time at the end. We'll finish on time to do that. So we'll start with Chris Van Gorder. And I am particularly pleased that Chris was willing to come today. He was supposed to be several other places, but I think it shows his dedication and commitment to quality, as you'll hear it from the position of a CEO. And it is not just we, the doctors and surgeons, that are interested in the quality of healthcare. Chris?
Thank you, Brent. Well, first of all, thank all of you. And it's not every day that a hospital administrator is invited to speak with an illustrious group of surgeons and physicians. So I am honored to be part of this panel today. I am the president and CEO of Scripps Health, but I'm also the immediate past chairman, which is the president equivalent for ACS and the American College of Healthcare Executives. And in that role over the last 7 years, actually on the board of governors for ACHE, I've had a chance to travel around the world and certainly across the country. And it's been fascinating for me, no matter whether it was South America or Europe or anywhere in between. There are 3 issues in every country, regardless of a fee-for-service system, a socialized, universal healthcare system, or no system at all. The 3 issues they're all talking about is cost, quality, and access. Simple as that. So there is no perfect system anywhere in the world, and I think everybody is trying to do what the American College of Surgeons is doing right now, is finding ways of creating more value for our patients and our society by finding ways to lower cost and improve quality. We clearly have a broken healthcare system. Healthcare has been unaffordable in our country for a long, long time, and frankly, it was just kind of screened or veiled by our national fiscal and tax policies. But now that our debt ceiling has become a real national issue, we can't be behind the fact that healthcare really is unaffordable in our country any longer. One of the things I try really hard not to do is criticize the federal HHS or CMS. They do a lot of audits. But having said that, the Center for Medicare Innovation is busy trying to come up with a solution to all of our healthcare problems by coming up, frankly, with a flavor of the week. It seems like it's almost weekly that they come out with a new model for healthcare delivery. And to date, none of those have actually reduced cost and created great value. And so I believe American College of Healthcare Executives, and I'm not here really to speak for them today, but I believe that as healthcare professionals, surgeons, physicians, and healthcare administrators, the solutions are going to be found with us. They are not going to be found by the government. And so I think, again, a lot of the initiatives that are going on right now with ACS is very important. At Scripps, what we're trying to do is kind of follow a couple of different paths. One is to redesign the healthcare delivery system ourselves. I often say that we're in a sick business. Historically, if you aren't sick, we're out of business. And I think we are shifting now to become a healthy business by trying really to focus on the ambulatory piece of our business, which frankly has been fragmented and disconnected from the inpatient piece for forever. And connecting these pieces, focusing on populations, but at the very same time not forgetting that healthcare is delivered to individuals one person at a time. And that focuses a little bit back on our genomics work that we're doing. We know for a fact that there's a lot of therapies and pharmaceuticals, for example, that are prescribed to populations because it's the best knowledge we have, but because of the genomic makeup of the individual, maybe that drug can't even be metabolized. And we believe that there's billions of dollars of healthcare waste. And so if we could actually harness the genome and customize or individualize care, we could reduce cost. So combining a redesign of the delivery system with focusing on individual care for population management really is the focus to go. 2 minutes, wow, okay. And then obviously we need to reduce what we call non-value-added variation. Very important. And so what we've done is we've literally flipped our company on its side. We pulled the chief operating officers out of the hospitals, responsible now for a function, be it imaging or something like that, across the entire healthcare system. All of the hospitals and ambulatory combined, looking for non-value-added variation. And we believe we can improve quality, reduce cost, create more value for our patients and for the organization if we do that. And then the IT piece is important. If we don't have data to give to our doctors and to all the folks that we have in our organization working on quality, we can actually not improve the quality. And so NSQIP Ralph Dilley, Dr. Dilley, and our organization really took the lead on NSQIP, is one of those tools we have to use. So let me just kind of conclude with Ian Morrison, who's a futurist, his comment. If you know Ian, he's a Scotsman and a brilliant futurist. And back in September, when a healthcare administrator was complaining about all these changes that were coming, he just answered it this way in relationship, is it fair? Is it fair that we're facing all these changes? He said, dude, let me rephrase that. Medicare, and I think we could actually put all payers in this, Medicare doesn't pay the income aspirations of you and your people for doing things exactly the same way you've been doing them for 25 years. Change the way you do the things you do like every other industry has had to do over the last 25 years. So dudes, it's our time.
Those of us who know Chris, Chris was a cop before he became an administrator, and he's never lost that. In addition to being a CEO, Chris leads the San Diego Search and Rescue, so and as an EMT, David. So I think, Chris, you do qualify to sit up here with a bunch of operating surgeons. Dr. Talamini.
Hi, my name is Mark Talamini, and it's thrilling to have a room full of folks interested in this topic this morning. And San Diego has much to be proud of, really. We have David Hoyt from UCSD, Dr. Eastman, and really they form the leadership of the American College of Surgeons from right here in San Diego, and it's great to welcome David back as really the product of UC San Diego, and he spent many, many years working there, germinating some of the things that I'll tell you about very briefly. So I would like to take my moments to tell you how these really 4 points, and I brought them up here, have played out at UC San Diego. It's through the agency of a quality council that meets twice a month for 2 hours. It's run by Angela Sosha, Dr. Angela Sosha, who is our Chief Medical Officer, who's here this morning. And this is a high-level committee with chairs, the administration of the medical center, interested parties, and it does exactly what Dr. Hoyt pointed out in terms of these 4 areas. It identifies what the priorities are going to be for the organization in terms of quality. It decides what metrics we will use to measure that quality. It comes up with tactics to drive change to improve the quality, and then groups report back to that committee, finishing that circle. So I'll give you just a few examples in surgery, and surgery, of course, is intimately involved in this. The first is through the agency of that committee. We did crew resource management training for all of our surgeons. And the deal was, if you wanted to operate in our operating rooms, you did the training, including checklists, timeouts, debriefs at the end of the case so that we have a cycle of improving each case. And we continue to drive that even now 4 years after that initiative. A second exciting endeavor where we've seen change occur that's specifically a surgical issue is central line infection rates. A few years ago, those were in the 4 to 5 range, and I believe when most of us trained in surgery, we would have said that number can't go to 0. Sorry, can't happen. Our team began thinking about ways that we can drive that number down. It used to be about 5 per 1,000 patient days at UC San Diego. Our most recent quarter, the number was 0 for the quarter, 0 in central line infections. Again, demonstrating that this process of coming up with strategies, coming back to the committee over and over again, where are we making progress, what's working, what is not working, can actually result in great outcomes. Third example is we are a NSQIP hospital. We have been for the last 5 years, and that becomes a treasure trove of potent data because it's risk adjusted, it's down to the individual surgeon, and again, we bring that data back to this quality committee on a quarterly basis and ask the question, what do we need to do to improve those numbers? And our most recent data for general surgery mortality, which we just got last night, in fact, shows that we're in the top 10% nationally for mortality in general surgery operations. Again, demonstrating that this cycle of identifying what the priority is, developing tactics, can actually work. Finally, what I would say is, as Dr. Hoyt showed you, we've invested a large amount in a training center, an ACS approved training center right across the way. And we have many objectives for having built this. I believe it's one of the finest such facilities in the world. But put simply, when 20 years ago when you finished training in surgery, you got a certificate that said you can do any operation for the rest of your life. Well, we now know that makes no sense because surgery is changing every 5 years. We have surgeons on our faculty and others in the city doing things that are not done anywhere else in the country. So how do we continually train our workforce in these new ways? We can ill afford to put any trained surgeons on the shelf for lack of training. So having these sort of centers where surgeons can come, relearn procedures, hone their skills is another part of our surgical quality improvement. So I thank you very much for the opportunity to share how this is working out at UC San Diego, which gave the world in many ways Dr. David Hoyt. So thank you.
If you're wondering why everybody is so on time, would you show them your red cards?
It's very effective.
Wait, I haven't started yet.
When we talked about this panel, and there could be many of you who are sitting here who could and should be on this panel, we really felt we would be remiss in San Diego with our history with the United States Navy to not have a representative from the military and specifically from the Navy. Does anybody know what the largest hospital in San Diego is?
Was.
It was, when it was here, the hospital ship Mercy. So that is something that we're mindful of, that in times of war, that we have the privilege of helping train some of the people who take care of the wounded warriors, and in times of war we have a chance to go and participate in military operations on a medical basis. But my trip to Landstuhl, Germany told me that there is no better trauma system. David talked about the trauma system in San Diego. There is no better trauma system, in my estimation, in the world than the Joint Forces trauma system taking care of the wounded warriors today. So, Mark, it's really a pleasure to have you be on the panel.
Well, thank you very much. I'm glad to be here. I'm surrounded by so many distinguished speakers. I feel like I need to say very little and turn the conversation over. I'm the token anesthesiologist. And but that's an important point. Currently, my position at the hospital is a deputy commander, so I'm the chief operating officer for the hospital. And in anesthesiology is sort of the add-on. But it's important to note that the American College of Surgeons recognizes and has for a very long time that it's not just about the surgeons. It's about every single person involved in the care of the patient in the surgical environment. And all the professions have come together, and the fact that we have several professions represented on the panel and in the audience, I think, speaks to that. And I think we had a nice discussion about that in the opening remarks. NSQIP is an important first step. It's outcomes-based. It's a way of looking at patient care that focuses on not indicators or good practice or best practice, but how did the patient actually do? And that is powerful, powerful information to have. And it's not just the surgeons that care deeply about that. It's everybody involved in the care of the patient. So NSQIP is an incredible tool because it's so fundamentally focused on the outcomes of the patient. NMCSD has been involved in NSQIP since 2004. In fact, we joined the VA in one of the early DoD pilots. And then the DoD took a great interest in NSQIP and working through the Health Affairs, so that's the large organization that all of the funding flows through, has worked with the American College to figure out a way to get all of the MTFs involved. I think we have 19 participating institutions at this point. Not an easy feat because DoD hospitals in particular are held to some federal legislation requirements that really don't allow us to share our data openly with our outcomes or QA data openly. But the American College has done incredible work in working with us at the DoD level to figure out a way to separate out the data and allow us to be able to look at how our patients are doing in comparison to the national and yet meet the U.S. code requirements that we have to follow. Why all this effort on NSQIP in particular? The military is often the training platform for future surgeons and anesthesiologists that go into the communities. And I'm sure many of you in your hospitals have many staff that have come from the military. So we have an obligation to teach them that. But we also believe that NSQIP and other quality programs actually improve the care. It does work, as has been so poignantly pointed out today. The other challenge we have in the military and in Navy medicine and at Balboa in particular is we are, at the end of the day, the uniformed medical officers are, at the end of the day, on a surge platform. We're hired by the American people to go forward, to be operational, to be that expeditionary medical force that joins our operational forces, surges forward for humanitarian relief, disaster relief, whether it's in the U.S. or overseas. So having employees that are coming and going makes it even more complicated to track quality. And this gets back to why NSQIP, I think, has proven to be so valuable to us. Lastly, quality and the focus on outcomes and team-based approach is a little bit about culture, and I think that's been addressed somewhat today. But my view is that the only way, well, the old saying that culture eats strategy for lunch is absolutely applicable here, and that even now, 7 years later in the NSQIP battle, we still view it as hand-to-hand combat with a culture of the individual practice, the artisanal approach to medicine. And it's the kind of leadership coming from the American College, it's the kind of leadership coming from the very senior leadership in all aspects of medicine that's going to drive this debate to where it needs to go. So I'm very happy to participate in this, and I thank you for the invitation.
Thank you, Mark. I began by asking what's the largest hospital in San Diego, the hospital ship Mercy. Chris Van Gorder commissioned a history of Scripps Health. I know all about it because my wife is the author. It was just completed, and one of the facts in there is, there's a lot about the relationship with the Navy, but one of the facts is that at one point, Balboa Hospital was the largest hospital in the world. Anybody want to guess how many beds there were at the peak at Balboa? Admiral, disqualified, conflict of interest. By the way, welcome, Admiral. 10,000 beds. After Pearl Harbor, the Pacific Fleet was, of course, moved to San Diego, and it's all history from there. But we'll move on, given the timing here, to our next panelist, who is a friend and a colleague of mine for many years. Ralph will introduce himself. Ralph and I have one thing in common. We both did our vascular training at UCSF in San Francisco in the 60s. And somebody once said, if you remember San Francisco in the 60s, you weren't there. Ralph, I remember, and I won't ask you to commit whether you remember or not.
Thank you very much, Brent. I thought with my time I'd give you some few concrete examples of what a hospital can do with an NSQIP program. About 6 years ago, we decided to try to put in place the NSQIP program at Scripps Green Hospital, where I'm chief of surgery. We were convinced that this would be an outcomes program would be far superior to the many quality initiatives that hospitals were asked to evaluate. Most of those initiatives were process-type problems. Very few were outcome types problems. And we felt that the NSQIP program represented the best possible outcomes type approach. So we started NSQIP 6 years ago, and our first report looked pretty good. You know, we weren't outliers in any of the postoperative complications, but we decided to just take one postoperative problem, look at it in great detail, and see what we could do. And we chose urinary tract infections. We found that our urinary tract infection rate postoperatively was 1.8%. The national average was 1.1%. we put together a committee that looked at all the urinary tract infections at Scripps Green, and we didn't find anything earth-shaking. But as a result of the committee, we did an intensive education program about postoperative urinary tract infections, about the management of the catheter, and about when a catheter could be removed. This was before SCIP criteria picked up the urinary tract problem. We've monitored our urinary tract infections over a period of 2 years, and over a period of 2 years, it fell from 1.7% to 0.6%, a remarkable reduction. So you could just see from that one very simple analysis the huge improvement in urinary tract and postoperative urinary tract infections, which saved a great deal of money and improved quality for those patients who didn't develop the urinary tract infection. Our second look was with DVT and PE. We were concerned that the DVT-PE incidence in our general surgery population was a little high. It was certainly not an outlier, but it was the OE ratio, I believe, is about 1.8, or almost 2. So we took the SCIP criteria and we looked at all our DVT, PT, PE problems, and we analyzed them before SCIP and after SCIP. And we were able to demonstrate a huge drop in the DVT and PE incidence after SCIP criteria were introduced. So that's a second type of problem that we were able to manage. Our third was a much more embarrassing problem. One of the reports showed that the surgical site infection in general surgery and vascular surgery was 7.8%, a true outlier. And the national average was about 2.9%. I was very embarrassed because it's my own service. And we rapidly put together a team that looked at every surgical site infection that we had, and we were able to identify the problem. We initiated an education, and we were able to demonstrate by the NSQIP criteria a marked fall in surgical site infections over a period of about a year. So that we're now down to about 1.8%. So NSQIP for us has allowed us to decrease the number of urinary tract infections, decrease the number of pulmonary embolic disease and DVT, and an early recognition of a serious problem with surgical site infections, and allowed us to implement changes that would improve that and to monitor those changes on an ongoing basis. I'd just like to finish by one fact. And at the last NSQIP national meeting, Matt Hutter at the MGH and a group did an analysis of postoperative infections. And it's an important thing to keep in mind. If a hospital system or a hospital can decrease their postoperative infections by 1%, just 1%, the savings is huge. Huge in terms of cost and huge in terms of patient care. So there's no question that this kind of an outcomes-based program is vitally important to control costs and improve quality.
Thank you very much, Ralph. I think you would all agree that Ralph has evolved from eminence-based to evidence-based.
No, I'm still very eminent.
Dr. Schumacher, we're particularly happy to have you in San Diego and, of course, California. Kaiser is such a critical component, takes care of more patients on an outpatient basis, I believe, than anybody else in San Diego. So you're responsible for the quality and care of a lot of patients. We really are delighted that you would join us and tell what you're doing at Kaiser.
Hi, I'm Mark Schumacher. I'm a general surgeon. I'm the physician director of the surgical services in San Diego. I want to expand in my 5 minutes on something that Dr. Kubelia touched on at the end of his talk. And that has to do with institutional culture. You know, Kaiser is a big supporter of NSQIP, but ultimately the outcomes are dependent on the people that institute the processes that you're trying to change. And that's one of the realizations that we had a while back. About a year and a half ago, we started in on a process of looking at our culture and seeing were there opportunities to improve it. And we started out with an objective measurement. We used the safety attitudes questionnaire that Peter Provenost and others have shown correlates well with clinical outcomes. And we found that we had opportunities for improvement in our culture. As we began to analyze our culture, we realized that in the operating room and the perioperative areas, we had very high-functioning individuals, but that each individual had an expectation that they were infallible and that the other people around them should be infallible. And there was a belief that inducing stress in others were something that would increase performance. Yeah. So we took this on starting out with group messaging. We had offsites and meetings where we presented presented to our folks what will happen to our institution if this continues. And we also gave them the message that we want to invest in you and we want to invest in a change. We brought in an outside consultant and an educator to teach effective communication skills to people. We taught our managers the concept of just culture. Just culture is the concept of holding people accountable, but it's also recognizing that we are not going to be able to eliminate systems issues, and more importantly, we're not going to be able to eliminate human errors by punishing people. That instead, it's more important to learn from adverse outcomes than it is to mete out punishment. We invested in giving people on the front lines the support that they needed to start identify the problems and making the changes to solve those problems themselves, as opposed to a top-down management style. And we've done this through using unit-based teams and through patient safety teams that are constituted of frontline people. We've also done one-on-one work. The leaders within the organization were encouraged to focus on problem children within their management structure and work with them one-on-one. We've instituted scripted leadership rounding to promote safety and communication. We've got a new onboarding curriculum for new hires that stresses the importance of teamwork. And we've done consistent messaging. You have to just keep bringing this message back to your people over and over and over again in as many different forums and as many different ways as possible. So in this last year and a half, I've seen some dramatic changes within the institution on my own executive roundings. And I'm looking forward to this fall when we're going to have our next rounds of the Safety Attitudes Questionnaire that I'm convinced is going to show us objective measurement in our culture. Change in our culture.
Thank you very much, Mark. That's a very different perspective, and hopefully will elicit some response to that particular approach to this problem. Our next panelist, David Chang, is not a surgeon. He's not a physician. He's a PhD. He may be the smartest person on the podium. David came from Johns Hopkins, as did Mark Talamini, actually. We have rated Johns Hopkins, but David, I've had the opportunity to write a paper with David, is a true academician in the realm of healthcare policy. I think you'll see his name more and more as really producing the evidence we all talk about. So, David?
Thank you, Dr. Eastman. It's a great honor to be here again. I am the only outsider in this panel. I am a health services researcher by training with a background in health policy. I'm actually fortunate to be in departments of surgery all my professional life, first at Johns Hopkins and now at UCSD. So I kind of come to this with sort of an outsider perspective. I'm very fortunate to have mentors like Dr. Freischlag, Dr. Talamini, Dr. Eddie Cornwell, who kind of brought me into this fold. And I have sort of 3 points to make. First is, what does this mean to me as a health policy person? And I think from a health policy perspective, what this means is this is an attempt at more organization in healthcare. And this is what Dr. Hoyt talked about with the Institute of Medicine report. Institute of Medicine report have talked about this issue of lack of systems in healthcare. And this is a problem that's causing medical errors. This is a problem that's causing fragmentation that we talked about before. And I think NSQIP represents a unique, innovative attempt at more organization in healthcare. And if you really think about this, we don't actually have a lot of organization in healthcare today, with a notable exception in trauma, as has been pointed out. And I think it's probably not a surprise that we're here today with trauma surgeons like Dr. Hoyt, Dr. Eastman, who really started this in San Diego decades ago. And in fact, many of the trauma system innovations, like the National Trauma Data Bank, came out of UCSD under Dr. Hoyt's leadership. And so I think when we talk about quality, what I see as a health policy person is more organized systems of healthcare. And I'm excited because I think it's about time that we push for this systems message out into the policy world. And I'm excited to hear the concept of professionalism really should be equal to accountability. And that's an issue I think hasn't really been addressed in healthcare. And I'm also excited that this moved from eminence-based to evidence-based. And again, this is probably why I'm in the audience. I'm probably the most junior person on the audience, and I think this culture of evidence-based allows someone like me to be able to speak up with evidence. And this is something where I work with a lot of medical students and residents, and I really try to encourage them to speak up with evidence. So that's what I see as a policy person personally. And what I think this represents to other people in the policy world is this message that we should be focusing on quality. Problem with policymakers is they often focus on money. And that's the only thing they understand. If you think about the discussion, all the policy debate is really about how to spend money. And I think this is really inappropriate, at least when it comes to healthcare, because I think focusing on money is really misguided. It won't actually save money. It will actually cost more money in the long run. And so what we should really do is focus on quality. As the data has shown, focusing on quality actually reduces costs. So you might spend a little bit of money up front, but we should see that as an investment. Ultimately, it will save money in the long run. And I think this is an important message to get out to the policymakers. And so I'm glad the American College of Surgeons have actually involved policymakers in this process. And we're trying to do that at UCSD at the local level, engaging some of the policymakers here at California. But I think most importantly, as a policy person, I think what's important is what this represents to the larger society outside of healthcare. And I think that might be the missing point in this whole debate. We might be preaching to the choir. Everyone in this audience understands this quality message. But it occurred to me when I started working with medical students that medical students don't understand NSQIP. Most of the medical students who rotate through surgery have never heard about NSQIP. They don't know this concept of risk adjustment. And if students don't understand this, I bet you 99% of the patients out there don't know about NSQIP. And I'm glad to hear the approach that the college is taking, this housekeeping seal of approval. And this is what we really need to get out to the society, that there are objective ways to measure quality, and patients need to start to demand for this. And again, this is a bigger problem than NSQIP. The society in general does not understand quality, do not know quality can be objectively measured. And so this is actually such a problem that the government actually just put out a huge RFA to look at how to report quality in a way that the public understands. And so this is something where I'm glad that the college is actually taking the lead. And so I think it's actually surprising in closing with this is sort of my closing thoughts, surprising that in the state of Facebook and Yelp, that it's surprising that most of us still pick our doctors based on an alphabetical list provided by insurance companies with no quality data to guide us. And so I think we're very lucky to have leaders like Dr. Eastman, Dr. Hoyt, my mentor, Dr. Talamine, and others on the panel who actually can get this started. But I don't think we could do the work ourselves. We really need to get the public involved. And I think in closing, I really like the video at the end of Dr. Hoyt's talk. I think that's probably the funnest way to deliver this message of quality that I've heard of, because most people think of quality, this really dry caterpillar plot, and I think that's probably the coolest video I've ever heard about a scene about quality. And it actually reminded me, one of the medical students actually showed me a video that some of the UCSD medical students made. It's a rap video about medical school, about how they study for the boards in the library. And so maybe that's the next step, get one of the medical students to come up with a rap video about quality. Thank you.
Thank you, David. Our last panelist, I'm particularly pleased to introduce. He'll introduce himself, and we're right on time. I really think that Jim LaBelle at Scripps has really recognizes two things. Chris Van Gorder talked about horizontal integration. He talked about co-management, that we're never going to succeed going forward if we aren't managed by a very collaborative relationship between physicians and the hospitals. And we read the history, David, we know it's come and gone. There have been chasms in the past. Jim LaBelle, emergency physician, but he was really the only one of only two new appointments in the whole structure that Chris created, and it is a physician vice president of medical management, co-management, and quality. And so I thought that Jim could tell us what the heck that means.
Thank you, Brian. My name is Jim LaBelle. I'm an emergency physician who sometimes pretended to be a surgeon, but recently took a role with Scripps, which the title is the Corporate Vice President of Quality Medical Management and Physician Co-Management. And I briefly wanted to touch on why those are connected, because I think that we've gone from a world in which quality is a department in a hospital and really has become an attribute of the organization. And intimate to that is how we connect quality to the bedside, and it really is about physician leadership and engagement around that. And because we're in a rapidly evolving environment in healthcare, it's a little bit of a struggle to keep up with the various aspects of how we're moving forward with quality and deal with the affordability issue as well. And I think that it really comes down to how we build a system in which of the future, how we re-engineer care. And physician engagement is crucial to that, and systems which drive measurements of outcomes rather than process is much more meaningful to the individual physician. If I can speak to you with risk-adjusted data around mortality rates or particular complications, then we can have broader conversations around the entire system of care rather than a particular measure which looks at, did I provide DVT prophylaxis for the patient? And I think that this is crucial because until we can recognize that our systems of clinical care evolved and were never engineered in the first place, and have deep conversations laying out how we want patients to get cared for and what the key performance indicators are that support that care process, we're not going to get to those systems that reduce complications and improve the efficiency of care. And I think that in this world, we simply don't have a choice to go about that. The affordability issue in healthcare is almost to the point now where it precludes conversations about quality. And until we can connect those two tightly, we're not going to be able to make that work. Which comes about really back around to what Scripps Health is doing to make this happen. And I think that what's really happened at Scripps over the past 18 months is building a management infrastructure to support the physicians in change. And Chris spoke briefly about the horizontal management infrastructure, which is really about doing things the same place, the same way. It's not really about, having the same labor standards or using the same supplies. It's about building systems of care that apply things the same way in the same place. And I'd like to give sort of one example related to my profession. Is about a year and a half ago, the ERs of Scripps recognized that we weren't performing to a level that we needed to perform, neither in turnaround times, access to our physicians in the emergency departments, or frankly, our bypass times for the EMS system, and had to have a hard conversation around why that was. And we came to the realization as a group of ER physicians across the system that it was really our leadership or relative lack of leadership that resulted in this. And we were in fact using triage and the EMS system to modulate the volume of patients that were coming into our emergency rooms for our convenience, not built around the patients. And what's more, the processes that we had built in the ER were really physician-centric. We weren't communicating well with the nurses, and we weren't engineering processes that met the information needs of the patients. And that was a struggle to recognize, and I think that was a prototype of the kinds of conversations that have to be had at every venue, and it can only be had by physician leaders. And surgeons play a particular leadership role in the hospital, in that the most expensive care and the highest risk to the patient is around the surgical care of the patient. And there's almost nothing in a hospital that isn't touched by the surgeon. So there's a huge role to play here. Suffice to say, our conversations came around and we recognized that it was no longer an option for us to use triage as a way to hold patients in the waiting room. we had to allow our patients to come back immediately and get care. And we eliminated largely the triage function in all of our ERs. It was no longer an option for the ER physicians to go separately to the patient from the nurse and make the patient have conversations twice with the nurse and the physician around the same historical data. We needed to go together as a team. And I think this teamwork and collaboration piece is going to be echoed and reflected throughout our culture. And it's not going to feel great when we recognize how difficult it is to operate as a team when we're used to autonomy and not collaboration. And I think that one of the core ideals around NSQIP and the fact that we're using risk-adjusted data that has been vetted by peers is that it really allows deep conversations that require collaboration between surgeons.
Thank you very much, Dr. Bell. Well, thank you. It's a daunting task to say everything you have to say with the expertise sitting here in 5 minutes, but they did it. And we do have the remaining time to open it up for questions. What we'd like to do is have succinct questions and direct them to one of the panelists. That person can answer it. If the others have something to add, they can. So, are there any questions? Yes. And would you identify yourself, what you do, and your question? That's not working.
Okay, I'll try it again. I'm Peg Ford, a patient advocate, and really privileged to be here this morning. I'm also a member of CUE, which is Consumers United for Evidence Healthcare, which is Johns Hopkins Center for the Hoffman Collaboration, and I've also had the privilege to be on peer review and also guideline panel. And I want to thank you to be here today and hear what you have to say. Where you're moving healthcare is so important to the community. So I just wanted to say thank you. But I really wanted to acknowledge Dr. Chang because I think what you're actually saying is true. How to reach out into the community, and your advocates can be that bridge. So reach out to your advocacy associations and actual patient advocates. Thank you.
Thank you. 1 for Dr. Chang, 0 for the rest of the panel. Dr. Dan, do you want to introduce yourself, what you do, and they'll get you a microphone that works quickly?
I don't think I need one.
We're giving you one that mutes.
Yeah, I'm always shy and demure. First, I'm Imad Dan, I'm one of the trauma surgeons at Scripps Memorial Hospital. First, would like to thank Mr. Van Gordon for calling me a dude. I'm usually called an old man. But, the question, actually, I don't know who I should direct it to.
Well, just throw it out and we'll decide.
Okay, so I'm going to throw it out. How can we explain different outcomes and processes that are being used for quality improvement or quality measurement, either in the same system or among different hospitals, and having different results while you are using exactly the same measures? Let me say, for eradication of urinary tract infections, for using the ventilator-related pneumonias, so different places are using exactly the same measures to prevent those, but coming up with different results.
Okay. So we'll, if anybody understands the question, I would like you to volunteer to answer it. Good question, Ahmad. Go ahead. Whoever.
Well, I think your question really revolves around this issue of risk adjustment. And that's where NSQIP has made a major contribution to this world of data collection and analysis. The problem, of course, is that no risk adjustment system is perfect. And I think we recognize that the NSQIP risk adjustment system is also not perfect. But that doesn't mean that we shouldn't try and make it as good as we can. And I think the college is committed and already has modified the system as we go forward on the basis of researchers like Dr. Chang and others to continually improve it. And I think we just have to acknowledge that no risk adjustment is going to be perfect enough to exactly compare one hospital's results to another, but that doesn't mean we shouldn't do it.
Yes, Ralph.
Yeah, I think it's a very important question, too. And I would just add to what Mark said is when we looked at the urinary tract infections, not a single member of our group felt there was anything wrong. we were doing everything right. But until you actually look at all of the infections, case by case, and look at how they were cared for, you then bring up these very, very small variations between practitioners that ultimately cause an increase in urinary tract infections. So I would say that if each hospital using the same outcomes program like NSQIP looked at their conditions in very great detail, we would have a lot of unanimity of opinion.
Chris?
And I also think you speak to the risks. I mean, we've grown up as silos. All of our hospitals operating very independently, picking different systems, and using the data in different ways. I think there's great importance with getting much more standardization in terms of the systems we use and the data we use. I mean, we've just now migrated to a common lab information system. Prior to that time, with an electronic health record, we actually had 2 different lab results with different standards going in the same one electronic health record. Actually a huge quality risk. So we have to standardize the systems we use, and then we'll be talking the same language.
Thank you. Yes, Ralph. First of all, wait, get the microphone, Ralph.
Wonderful clarity on the presentation, and you've got all the pieces together. Patient advocate here obviously addressed some of my concern, which is...
Would you introduce yourself, Ralph?
Oh, I'm sorry. I'm Ralph Ocampo, a retired general surgeon, former CMA president, if I may be allowed to say that. So I've been in medical politics for a long time, but that's not what I'm addressing here. I have a question for you, Brent. Is this going to become an annual event? Number one. Then the second question is, since this affects so much of our community, for instance, the Chamber has a health committee. Wouldn't it be appropriate to always invite non-physicians to events like this? This cube is just so easy to understand. I understand it. If they understood it, maybe they could help us. And Dr. LaBelle is probably, for all of these institutions, going to represent the type of individual that's going to put this into effect.
Thank you, Ralph. I'll ask Dave Hoyt to, I think we would be happy as the San Diego chapter of the American College of Surgeons to make this an annual event if there was interest, and perhaps David Hoyt and Nancy can tell us if that's in the works. You talked about this being continued. And secondly, I'll let you know that we sent out over 1,000 invitations today. We tried very hard to make sure that we didn't just have the people from our quality committees and our surgeons, which is, I think, what we have. We had really hoped to get, Ralph, the people that you're talking about. We didn't accomplish that, so maybe we ought to do it again. I want to tell you, we also invited our colleagues, our surgical colleagues from Mexico, because we have a chapter in Baja California. Some responded. They were not able to come. They're probably still waiting to try to get across the border, but they too would like to be more involved in this. David, do you want to comment about this being an annual event? What's your plan?
Well, you know, our hope would be that this is important enough to the community and important enough to the conversation across the systems of care in San Diego that you would want to do this on an annual basis. And I think that is kind of a dream that we could see this occurring in every community, really to foster ultimately the communication with the public.
David, perhaps you could tell the story of what the college did in the 1920s and 1930s that you shared with us this morning. It's pertinent to this concept.
Yeah, I mean, we think, you know, ideas are always new, but in reading the history recently, it turns out that based on our chapter distribution of membership in that organization, that became sort of the central forum. This is before, you know, the internet, before video, before any of the modern technology we have. So literally, the educational show was taken on the road community by community. And in addition to spending the day teaching each other how to do surgical procedures, they would convene in the afternoon and invite the public to actually come and listen to what was going on. And it became actually one of the most popular sessions in communities, oftentimes drawing 200 to 500 people from the community in a small community to just come and find out what's going on with surgery. So maybe we can go back there.
And in the, should this become, Ralph, an annual event, let's talk about that here. I know Sharp is represented here today, have been one of the leaders in quality in this community for a long time, have a quality event. a week from this morning, Scripps is having its 5th annual Quality Summit, and I would invite all of you, if you're interested in coming, to come. It's at the Del Mar Marriott, sort of the same time. It's going to take a little different approach. It's the title of that is From the Genome to the Bedside, but it's going to touch on some of the issues. The keynote speaker is Abraham Verghese, professor of medicine at Stanford, author of Cutting for Stone. And we're going to have a panel where he is going to be paired opposite of Eric Topol, who has just published a rather provocative book on the creative destruction of medicine, and it's all about technology. So we're going to have Abraham Verghese, who talks about getting back to the basics and the stethoscope and listening to the patient, and Eric Topol, a futurist clinician, cardiologist, who says he hasn't used a stethoscope in 5 years. He thinks we should be using handheld ultrasound and look at the heart. You're all invited. If you want more information, we'll be happy to provide it. Other questions? Yes.
Thank you. I'm Scott Musican. I'm one of the vascular surgeons here in town. I have a question about the concept of the electronic health record and the fact that it seems like unless there's integration of all the hospital systems with an electronic health record, costs are never going to be improved. Information's never going to be shared. I mean, we have patients that go from Sharp and get transferred over to Scripps, and you know all their studies are being repeated once they get there because they can't see the information. And so I want to know what's being done to try to integrate the electronic system so that costs can be brought down and things are not repeated over and over.
Yeah, that's part of the government's push towards meaningful use in electronic health records, and there's actually a time frame built in for information exchanges that will connect the systems together. So I know Sharp and Kaiser and the government, all of us are working towards that point where we will be able to talk to each other. That's one of the requirements under meaningful use.
Yeah, but David?
Well, just another piece of that. One of the big debates is between the type of data you can get with risk outcome, adjusted clinical outcome versus so-called administrative data. And one of the barriers is that it takes an FTE in each hospital to sort of collect clinical data. But we're working very hard now with Epic, with the federal government, with several other large medical record vendors to actually focus on the way in which EMRs can drive data directly into data systems so that you could see a time in the future where the cost of actually sustaining these data systems would go way down because we'd really get rid of a lot of the FTEs.
We probably have time for one or two more questions, and then I do want to have the panelists have a chance to make a final comment.
We have a question right here.
Dr. Tyner.
Hi, Jeff Tyner, a thoracic surgeon at Scripps. And as such, we've been part of the STS database for quite some time, and my understanding is it's the oldest single specialty database in the history of medicine. It has a lot of data. And as such, it's been a real treasure trove for us. It's allowed us to move to extubation sooner, reduce transfusion, and look at readmissions, all of which have improved quality and reduced cost. But there's two real issues that we've identified along the way, and one is whoever gathers this data is very, very important, and I'm interested in how you plan on establishing that because there's a huge difference in definitions and who gathers this information, and it really goes to the quality of the data. And the second issue is, as David Chang mentioned, it's very, very important. Very few people in the public or probably in this room understand confidence limits or standard deviation. So when it comes to public reporting, you have to be very, very careful how you release this data. Not that it shouldn't be released, but it has to be in some sort of palatable form, and I'm interested in how that's being addressed.
David, you may want to speak to that, and certainly any of the panelists that do. Very important question.
Yeah, I think with regard to the first part, we will see, but presumably by formatting adequately the field choices in electronic medical record, you can drive consistency in data entry. And that's still theoretical, but that's the hypothesis. In the meantime, NSQIP data is all collected by trained nurses who are subsequently audited, and the concurrence rate of inter-rater reliability is pretty low. And the second, I forget the second question.
So does he. So
has to do with public reporting.
We have a project with CMS, and in fact, STS is part of that project as well. STS has been a leader in public reporting in working with consumer reports, as I'm sure you're aware, and developing metrics that are clear to the public, but account for the kind of variability you're talking about. Consumer Reports has done. The second is CMS, and they're looking very carefully at this as well. On a prototype basis, you'll start to see in the hospital compare website, those hospitals that want to post some of their NSQIP data can start to do that to get some experience. The third opportunity, though, which is really one of the strongest, is the California Healthcare Foundation, obviously here in California, has put out an RFA to work to start public reporting on 3 diagnoses, normal delivery, cancer, and I believe an orthopedic procedure, because their concept is that these are usually out in the distance a bit, so that there's the opportunity for patients to actually shop around a little bit. So we're going to probably work with them in the cancer area to try and develop relevant metrics that would achieve the goal of public reporting.
final question with Dr. Centura.
Dr. Eastman, and thank you for all your leadership, and you, Dr. Hoyt. It's a real bright, shining light on San Diego's contribution to the national level of surgical and physician leadership. My question is on never events. And as you know, never events are episodes, adverse episodes that occur within the hospital setting for which Medicare will no longer pay. And these include things like pressure sores, hospital-acquired infections, and falls. It also includes DVTs. And I was at a forum in Dallas last year where I had a chance to ask the medical director of CMS why it is that a hospital that is using A1 protocols for DVT prophylaxis, starting the chemoprophylaxis on time, using it in the right doses, in the right sequence, no missed doses, and for the right period of time. And if that person gets a DVT, that's a never event. In another circumstance, if someone has no DVT prophylaxis or the DVT prophylaxis is administered inappropriately, that's also a never event. And these things should be driving quality, not just designed as schemes for avoiding payment. And he said, and I asked him that exact question. He said, we don't really care about quality. We're just trying to find out ways to save money. And I would ask the American College of Surgeons to use its influence to modify the way never events are being administered. It is abjectly unfair to penalize a hospital for a never event when the patient care is perfectly organized around vetted protocols.
Thank you. Everybody in favor, raise their hand. I think we all wrestle with that. I hope in the area of surgery that the College of Surgeons, the relationship that David Hoyt is building with CMS, with the Joint Commission, with the people in Washington, that we can address that, because it is patently unfair. Hopefully adhering to guidelines that are approved by people like the College of Surgeons will also be a defense in the whole medical liability issue, which we haven't discussed. Well, in order to make our time limit, I would like to start with Dr. LaBelle. Just would like each of you to make one point that you have heard today, questions you've heard, something you didn't get to say. Dr. LaBelle.
I just would like to reiterate that even with the outcomes-based data, it still requires physician leadership to drive change in the system.
Thank you. Dr. Chang.
I just want to thank the comment about patient involvement. And again, I think the bigger message is we should learn to empower patients in this process. Again, let's go back to the evidence-based medicine. It's not just in medicine. Patients also kind of believe in that. And I think we need to change that from evidence-based medicine on both sides to be more patient-driven, patient empowerment approach.
Thank you. Dr. Schumacher.
I'd say that NSQIP has given us a very powerful tool and is the basis of quality improvement, of being able to look at our data and look at our processes. But we don't have to be afraid of the white elephant in the room of culture. There is a systematic way to go about analyzing and changing your culture. And I urge you at your peril not to ignore it.
Dr. Dilley.
Yes, I'd just like to reiterate my last point. It just takes 1% drop in surgical complications to have a very, very significant increase in quality and decrease in cost. And every group should be able to figure out to cut their postoperative complications by at least 1% and make that a goal for the year.
Dr. LaBelle, before we hear from the captain, what is the estimate of the waste in healthcare that if we decrease this inappropriate value-added variation, we can save?
I think nationwide, the estimates anywhere from $500 to $700 billion in waste in the system.
So we have an opportunity.
For me, it's all hospital systems are integrated because the patients move around. So we can't lose sight of that. And the question about the EHR, I think, spoke directly to that. And us recognizing that the silo systems and military is just as bad at this as everybody else is part of the problem. And we need to work at the leadership level to systematically break down those barriers.
Thank you.
So my point would be with regard to the electronic health record, which UCSD made a major investment in 5 or 6 years ago, actually when David Hoyt was still at UCSD, and Dr. Sosha pushed this. Huge investment, inconvenient for the physicians, no question, but incredibly valuable when it comes to quality improvement because of the data that you can collect. Can I do a second one?
Yes.
Okay. So a related issue, in our Center for the Future of Surgery, one of the approaches that we're trying to take, my colleague Dr. Horgan makes the point that in a soccer game, if you commit 1 foul, you get a yellow card. If you commit 3, you get a red card and you're out. Right now for surgeons with the State Board of California, there's only a red card. And we need to figure a way to retrain surgeons and help them at the yellow card stage. And I believe that we can do this in a place like we've created at Centers for the Future of Surgery. I think it's very important.
A very innovative concept. Chris, you have the last word.
Yeah, okay. Well, dudes, I guess my comment, I do a market news every day, and I survey all the literature that's out there relating to healthcare reform that I can get my hands on and manage in a day. And there are a lot of folks out there that are saying that the sky is falling as it relates to healthcare. It's terrible, et cetera, et cetera. I have never been more bullish about the future of healthcare. I think we're doing the right things. We're moving healthcare from sick to wellness. It doesn't mean we're not going to have hospitals dealing with acutely ill patients. Of course we will. But I think we're moving in the right direction. I've never seen this level of collaboration in more than 30 years in healthcare administration with doctors and administrators, all of us working together. We're actually going to improve the healthcare system, create more value for our patients and society. So I've never been more bullish.
Thank you, Chris. And I'll take the opportunity to conclude by thanking Dr. Hoyt and the American College of Surgeons for allowing us to be the community to have, I think, the first forum west of the Mississippi, maybe, and certainly the first on the West Coast. That obviously has to do with nepotism and Dr. Hoyt's foundation here. Dr. Cochran, we really appreciate you being here as a physician scientist who helped to train David Hoyt. Thank you very much. We're adjourned.